Welcome to the webinar, Communicating with Depressed Patients, sponsored by DocCom, whose mission is to provide engaging educational resources for healthcare professionals to enhance communication and health outcomes. I'm Barbara Lewis. This webinar will last about 30 minutes, and the recording will be available later. Please put any questions that you have or post your comments in the Q&A box. And let's get started. So joining us today is Damara Gutnick and Dr. Damara Gutnick and Dr. Dennis Novack. Damara is the medical director of Montefiore Hudson Hospital, Collaborative performing. Sorry?
Montefiore Hudson Valley Collaborative.
Valley Collaborative Performing Provider System, is that right?
Yes, that's it.
Okay. And Dennis asked me not to go through this whole thing because he wants to actually get going and have that conversation. So I'm just going to leave it up here for a brief moment and you can read through it. They both have unbelievable credentials here. Dennis is the founder and editor of DocCom and also Professional Formation, which is free for anybody who wants it. It's 13 modules on professionalism. And both of them are online training programs for students, residents, clinicians, and healthcare personnel. So let me just talk a little bit about DocCom. It's a proven online interactive healthcare communications learning system. We were founded in 2003 by the Academy of Communication and Healthcare and the faculty at Drexel University. Through a grant with the Arthur Vining Davis Foundations, we actually produced the modules. And then launched as a pilot in 2005, debuted as a nonprofit, and began offering continuing medical education in 2014. Approximately 90 institutional subscribers is currently involved with DocCom. 9 journal articles, which are on our website, talk about the value of DocCom. And we have been in 20 countries and translated into 3 languages. Here are some of the, not all of them, but actually some of the studies that have been done and where they've been published. Our module authors are leading faculty. We have 42 online modules with over 400 videos and annotated interactive videos and plenty of back end for the faculty. So Damara is actually the co-author of Communicating with Depressed Patients, and she and Dennis are going to have a conversation and talk about some of the tips and techniques of communicating with depressed patients. Damara?
Sure. Thank you so much, Barbara. And hi, Dennis. It's great to see you.
Good to see you.
So I'm so honored to be invited to talk about the module, the DocCom module, and some of the tips that we discussed in that module that really could help communicating with depressed patients happen more effectively and efficiently in busy practices. Just a little bit about myself, because I'm an internal medicine doctor. I worked for many years in an inner city hospital in New York City in an ambulatory clinic, which took care of the underserved, and depression was very, very prevalent. And it was very challenging to manage the depression at that point. When I first started working there, at that point, primary care doctors were not necessarily managing depression. We weren't screening for it. We weren't finding it. And we were referring most of our patients to psychiatry. And because so many patients were being referred to psychiatry, there was really no access in psychiatry. And over time, primary care physicians became more comfortable with screening for depression and treating depression within primary care. And that opened up capacity in psychiatry for the patients who really needed it, the ones that were more complex and a primary care provider alone needed help managing and needing consultation on. So I'm happy to discuss a little bit of what's in the module. It's the communication skills that can be helpful for managing depression and communicating with patients about depression. And I'll pass on to Dennis.
Yeah, I looked at our original discussion of 16 years ago when we first posted the module, and a lot of it is pretty current. Although there have been some there have been some new conceptual advances And perhaps we'll get Damara to talk about some of those, because she's been responsible for some of them. For two of the major ones, in her work with Steve Cole, brief action planning, and a new movement that's taking root in American medical practice, international practice, sort of the "What Matters to You" movement. But I'll just make a couple of comments. So I'm also a primary care internist, and I've been interested in depression for a good long time, and did a couple of studies in the late 70s, early 80s, actually, of how well physicians recognize depression. And we found, we did 2 studies in the outpatient and the inpatient settings, and found that about 50% of depression in both of those settings were missed by their physicians. And there have been some recent meta-analyses, one in 2009, one in 2013 or 14, that showed about 50% of depression in primary care is still missed. That the specificity of physicians is not so, is actually pretty good. But the sensitivity is still around 50%. And they often over-identify depression as well. So I think I have three goals for this next, 15 minutes. And perhaps we can have a little chat about how we might be able to do a better job of recognizing depression in primary care. The rates in primary care in different studies are anywhere from 10 to 20% of your patients, and it's higher in patients who are chronically ill. So, how do we recognize it? Are there techniques, either communication techniques or something we can institute as a practice, screening tools, et cetera, to get a better handle on depression in primary care? And when we recognize it, what key questions do we have to ask? And then a little bit on how do we explain it to our patients? Because a lot of people don't want to be depressed. They don't want to be recognized as depressed, and that's part of the reason we don't recognize it. There's a certain amount of shame in having a diagnosis of depression. So how do we relate a diagnosis of depression to our patients so that they accept it, understand it, and want to do something about it? And lastly, just a few general approaches. I mean, medication treatment. I think a lot of docs know medication treatment. There's some newer treatments. It'll take. We can't get into that in 25 minutes. But really, you can learn pretty much everything you need to know pretty quickly in terms of medication treatment. But there are other sort of structural approaches in your office to making sure that you're treating depression effectively in your patients. So that's a lot for the next 10 minutes or so. But I also see that there are over 20 people on this webinar right now, and please put some of your questions in the chat, and perhaps we can have a discussion. We have to end at about 3:25 for Barbara Lewis to make some final comments. So Damara, why don't you? I saw you writing notes to some of my questions. So why don't you get started, and I can add my 2 cents.
Oh, I'd love it. I'd love to. So, Dennis, as you were speaking, it brought me back to the first role I had at Bellevue and how we started to get to know each other and meet each other. And that's when I became the physician champion when we were launching a depression collaborative care team at Bellevue Hospital, where I worked for many years. And as part of that process of doing collaborative care, building up a collaborative care team, I was part of a collaborative that was run by New York State. And we had to start screening our patients for depression, but initially it was just an N of 1. So there were 30 providers 30 attendings in our clinic and multiple residents, but it was N of 1. It was me screening all of my patients for depression. And I learned so much from that process because we were using the PHQ-9, and which is a 9-item screener for depression. It asks about mood and anhedonia, the first 2 questions. It aligns with the DSM-4 criteria or DSM-5 criteria for major depressive disorder, and asks about the SIGI CAPS questions basically in this 9-item screener. And I discovered many of my patients who I would never have expected to be depressed were really very depressed. And they didn't look depressed. They would dress very nicely. They'd really put on the 5s to come to, put on the 9s to come to my office. It was, a event that they wanted to pull themselves together for. But when they were at home, they were not managing very well. And they were, sleeping too much or not sleeping at all, and overeating, and using a screening test like the 9 was so powerful, because the PHQ-9, because it allowed me to see a glimpse of what was really going on. The PHQ-9 instrument asks those questions about how are you feeling in the last 2 weeks. So it's not today when you're in my office and you have that, you've pulled the energy together to come to me and put a smile on your face, but how have you been doing over at home? So it was very, very powerful. I remember one patient that I was just shocked. She was a grandmother who always came with a smile, always well dressed, and
Dennis, can you hear her?
No, we lost Damara.
So Damara, we've lost your audio. Did something change? It says that your mic is on. So Dennis, while take yourself off of camera and let's see if your audio is better. Maybe it's the bandwidth, because she looks like she's frozen now. So Dennis, do you want to pick up here while she logs back in?
Sure. Well, I'm not. I'm not exactly sure.
Very high on the peak.
Oh,
now I can hear you.
Okay, there you are again.
Can you? Oh my God, I don't know what happened. So, did you hear any of my story?
No.
Okay.
Except this grandmother who.
Otherwise, just press pound.
So what I was saying is that can you hear me now?
Yep.
Okay. So what I was saying is that I had a grandmother who I never would have guessed was depressed. She was well dressed. She was smiling in my office, but when I actually looked at the PHQ-9, she scored very high, and it was allowed me to kind of. I was surprised. I couldn't believe how depressed she was, and it allowed me to use that screening instrument to dig a little deeper and ask those deep questions about what she was really experiencing every day. The PHQ-9 asks about how you're feeling in the last 2 weeks, not just today. The patient was able to pull it together for the visit, but really was struggling at home. So it was a really very valuable tool to give me a glimpse into what my patient was experiencing. It was very powerful. And those kind of surprises happened quite a bit when I when I implemented routine screening into my practice. And that led to this N of 1 trial of just my patients. I actually uncovered that about 20 to 25% of my own panel was depressed, and I would never have guessed that.
Right. So did you institute PHQ-9 screening throughout your throughout all the practices you're responsible for?
Yes, so at Bellevue Hospital, we built a depression screening program, and we actually took the screening away from the doctors. So it was actually other members of the care team that did the PHQ-9. They started with the PHQ-2, and then that led to the PHQ-9. And so when the doctors saw the patient, they had the PHQ-9 score already, and then they were able to actually look at see what the symptoms of the patient was having and dig deeper to understand what the patient was feeling, and actually make the diagnosis of depression based on that.
Right. So, Damara, throughout this whole process, did you become a little more sensitive either to the nonverbal, paraverbal expressions of patients, or maybe to your own cues, internal cues about whether patients were depressed? Did your antenna become a little more sensitive?
Definitely. I think, as a clinician, I was always very sensitive to those nonverbal cues. But when you're able to see it on the paper, it makes it even come out more. When you see somebody, there's a disconnect to how people are smiling to you, or even the words that they're saying, and their emotionality and their what you're seeing on their face. And then you can call it. You could say, it looks like you're really having a tough time. It looks like you're depressed. It looks like you're frustrated. It looks like you're about to cry, and you could pass that tissue box and actually address that. That makes it safe, that that the patient feels heard when and it makes it safe for them to express themselves and open up. And it actually adds a lot of efficiency to a visit if you address that up front.
Yeah.
Many doctors, I think, are afraid to dig deeper. They don't want to open up the Pandora's box because I don't have time. I only have, 10, 15 minutes with the patient. I can't deal with the crying, but the crying only lasts for a moment, and you meet the person. Then it's you and the person, and then you're ready to really talk about what's going on. So it's a really valuable skill.
Yeah, let's talk about how you structure your practice, how people can structure their practice to do a better job of diagnosing and treating depression. Because at least in some of the studies that have been done, and the most recent meta-analysis, doctors often did not. First of all, even when they recognized depression, didn't didn't document it in the charts, and often didn't refer out. So, we have to create some sort of automatic practices that guarantee that our depressed patients get the care they need. You have some comments,
Sure.
sort of on the organizational level?
Yeah, so I think it's not just screening, but what's unique about the PHQ-9 is that you could use it to monitor response to treatment too, for the patient over time. So if you actually put in a system in your practice where you screen everybody, or once a year, or at major visits when they're coming to see you, but if a person screens positive, then you follow up that score over time, so you actually could see if they're improving. The way I think about it is that with diabetes, if you have a high A1C, you don't stop there. You don't just say, all right, the patient has a high A1C. You're going to keep managing that diabetes and escalating therapy, whether it's medications or other kinds of, or exercise diet. You're going to keep escalating it until you get it at goal. And so using the PHQ-9, for example, as a screening tool and also as a management tool, you could, as an algorithmic care tool, you could actually bring the data to that and use that to manage your patient with depression over time.
And I know in the module, you and Steve talk about using your care team, using your MAs, other members of your care team to follow up with patients and administer the PHQ-9.
Exactly. You could use, and that's, I think we got cut off when I was talking about that. It doesn't have to be the doctor that does the PHQ-9 screen themselves. So in our clinic and in many clinics I've worked with since, you have the medical assistant as part of the intake process actually does the PHQ-9, or now people are using apps and the PHQ-9 gets sent to the patient before the visit to complete, and then goes into the charts. The doctor has it ready and sees where to, it uses that to assess where to spend the time and what's the priority for the visit.
Yeah. So I just want to, I don't know if everybody does this by now, but when I've for many years, when I've made a diagnosis of depression, and we didn't even talk about screening for suicidality and the 4 Ps and the 4 Fs. And I urge people to read the module, because it's very useful information about how you screen and assess for suicidality. But when I make the diagnosis of depression, if I let people tell me their sad story, I go through the PHQ-9, then I ask about some of the specifics. by the of their situation, and often, by the way, there's adverse childhood experiences, physical and sexual abuse, at least in my population of inner city patients. That's what I've seen. I'm able to say, I think you're depressed. And they go, I go, do you know what depression is? And they really don't, and I must say I medicalize it. Damara talked about the hemoglobin A1C, talked about diabetes, and the hemoglobin A1C being similar to the PHQ-9. I say, look, it's just like diabetes, if you don't have enough insulin coming out, this is a chronic disease. If you don't have enough insulin coming out of your pancreas, your sugar is screwed up. If you don't have enough serotonin coming out of certain parts of your brain, your thinking and your feelings are screwed up. And I'm just, I'm going to recommend a medication. The only thing it does is normalize your brain serotonin levels. And, I just make it, I make it medical. I make it very simple. I don't talk about inflammation and CRP and the relationship to anhedonia and the different, neural pathways, etc. I make it very simple. And usually by the time I'm finished, and, and this genetic influences and this depression and alcoholism, it's all, by the time I explain it, which doesn't take a whole lot of time, they're ready to get, they're convinced and they're ready to get treatment. And, but I do want to just spend 2 minutes in some of these newer concepts, the brief action planning and what matters to you. And I wonder, Damara, if you might say a little bit about it, and then let's ask for a few questions.
Sure, of course. So what matters to you is a global movement. I first heard about it from Maureen Bassano at the IHI meeting in 2012 or 13. It started with a New England Journal of Medicine article by Michael Berry and Susan Edgemont-Levitan, and shared decision making and about what's important to the patient. And so the idea is to shift healthcare from what's the matter, which gets a cheap complaint like shortness of breath or my toenails turning purple, to what matters to you, what really is the issue. And when you ask that question, you open up, the patient to not just think about the medicalization, the diabetes, where the doctor is. I'm thinking about managing your chronic disease. It's about what is really important to you. And it might be my daughter's using drugs. It might be I'm at risk of being evicted. And the idea is to really listen and to ask what matters, really listen, and then be willing to shift your care plan based on what you learn. So you might look at a person's diabetes and say, this is out of whack and their blood pressure is high, and I need to spend the time today getting that under control. But the person says to you, well, what really matters to me is that my daughter's using drugs and we have no food on the table and the whole family's hungry. And so to go in there and say, well, why aren't you eating fresh fruits and vegetables? Because that would be better for your diabetes, or find time to go to the gym and exercise when somebody doesn't have money for food and they're worried about their daughter being on drugs. It's a disconnect. So asking that question really allows you to understand where the individual's at and meet them where they're at, and realizing that you can't just be pushing your agenda. It has to be a collaboration that meets the individual where they're at. When you start to manage the things that are important to them, and it doesn't necessarily mean that you have to fix them, you just have to acknowledge it, and I'm a trainer of motivational interviewing, and what I say is reflective listening. If somebody says, well, it's just really hard for me right now, I don't say, well, you should be taking your medicine. I say, wow, I can understand why it's difficult for you to take your diabetes medications and exercise when you don't even have time to manage, or you don't have food on the table. I can understand why it's a struggle right now. And it's very important not to label your patients as non-adherent or non-compliant. It's about really meeting them where they're at and understanding where they're at and having a partnership. So what matters to you is this international movement that's spread to over 50 countries now. There's, I'm going to talk in a few minutes about another module that we created about depression collaborative care, and there's a section on what matters to you there. And if you go to our Montefiore Hudson Valley collaborative website, there's a whole bunch of materials, including a toolkit on what matters to you and how you can implement it into your practice. And there's also an international What Matters to You, WMTY.world website that has amazing resources about what matters to you from around the world. So thank you for giving opportunity, Dennis, to talk about that.
It's extremely relevant to this topic. And I see there are no questions in the chat. I guess we've covered everything that any questions anybody has. Are there some questions? Well, Ann Reisner raised her hand. Go ahead, Ann. Barbara, can you unmute Ann?
Sorry.
Yes.
Could you put some of those URLs in the chat room so that you kind of went through them faster than I could write? And I really appreciate that.
So why don't you continue the conversation for a few more minutes since we don't have any questions, and maybe we can wrap up at 29 after.
All right. Yes, I don't think we have time for brief action planning. But again, that's in the DocCom module. And, the idea behind brief action planning is to really encapsulate the principles of motivational interviewing in a brief amount of time. Motivational interviewing was, first created and found to be very effective in the psychology world, and could take an hour or whatever if you really wanted to do it right. But Damara and Steve Cole managed to compress it into a few minutes. I don't know, Damara, do you want to say something about?
Sure, I can do it. I can do it in 2 minutes. So, what this is it's a self-management support technique that's based on the practice and the skills in motivational interviewing, but it's all completely like an algorithm out. Like, tells you the words to use, because the motivational interviewing and the open-endedness and the compassion is all built into the terminology. So if you go onto the DocCom module or onto the other module I'll tell you about in a moment, you could actually read a lot more about brief action planning. It's about goal setting, making a personal action planning that's focused, that's SMART goals, specific, measurable, achievable, relevant, and timed. You're asking somebody to actually think out the steps of that plan. What exactly are they going to be doing? When are they going to do it? How often will they do it? So really make it very, very specific. Asking somebody to repeat back in their own words the details of their plan, because there's a lot of evidence to show that when people talk about a plan themselves, they're much more likely to actually follow through on it. And that's in contrast to a doctor saying, so you're going to go to the gym tomorrow and you're going to do it for an hour. Instead, you have the person say it back out loud, because then they're judging whether or not that plan is feasible for themselves.
Yeah. Damara, do you want to put the other website up?
Mm-hmm.
So we only have 1 more minute.
Okay, so at the Montefiore Hudson Valley Collaborative website, if you go to Learners Central, which is under the, there's a whole bunch of training modules, and there's a module there, a depression module on depression management using the collaborative care model. In that module, as you can see on the slide, there are many different videos that you could follow the patient's care journey for depression, from the time of discussing the diagnosis, starting the medications, counseling about the medications, how to make a brief action plan with the person. And it also shows the different roles of the different care team members, like a care manager, following up with the patient at different intervals before they come back to see the doctor. So telephonic follow-up. There's also a video about counseling a patient with suicide. And you could show how you could, it demonstrates that you could have these conversations very quickly, very efficiently, if you actually get to the heart of the matter, name the emotions very quickly, and it can happen fast and not slow you down too much in your clinical practice. The module is available for free. It has 3 CME hours for doctors, nurses, and I think social workers. And once again, the website is here where it's available.
Yeah. So
Thank you so much.
So
Dennis,
great.
did you want to?
Well, yeah, since we did that module 16 years ago, and then Damara kindly revised it a number of times, the last time about 5 years ago. Damara and her colleagues have done amazing work and produced a lot of extremely useful videos and other materials. So I recommend that you. I've been on that website, and it's the really outstanding educational materials. So I recommend you go there. All right. So I think take it away, Barbara.
Okay, well, thank you so much. That was a really important conversation. And by the way, Damara did a .com podcast on what matters to you. And Dennis also has an important podcast episode on teaching communication skills. And that podcast name is Healthcare Communication, Effective Techniques for Clinicians. So thank you to everyone who has joined us today. The recording will be available on our website shortly. And let me know if you'd like a free trial subscription for .com so you can take a look at the 42 modules. And thank you very much, everyone. And thank you, Damara and Dennis. This was great.
Thank you.
My pleasure.